welcome. I think we've got everybody, and I'm sorry if there's not enough seats for everyone. So what we wanted to do, we'll begin the session, and we have a period of time. We thought that this would be very informal, and Philip has reminded me that nobody's wearing ties at the front. This is a measure of just how informal this is going to be. You can see the title of the session before us. I'm hoping this will be a stimulating discussion where we get your input. The intent here is that you heard in the plenary session that Health Quality Ontario is trying to incorporate equity as an important principle on everything it does. And so how could we as an organization support the planners for our healthcare system, the providers within our healthcare system, in incorporating equity as an essential domain of quality. And so to that end, we're trying to develop a strategic plan. And so there is some method in our madness that you're here actually to help us with that strategic plan and to give us direction as to where we can make an important contribution in the overall initiative as we build equity in all of our jobs. So we have a panel, and these individuals represent many different perspectives of the story of equity. Individuals with lived experience, and Madonna, I'll introduce her in a moment or two, but a star of stage and screen. She was before they presented in the video just a moment or two ago. And then Philip, Patrick, I'm going to introduce, but the lived experience, the provider, and the policy side. And we've asked them all to comment on issues of equity. Before we go on, I'll introduce myself. I'm Jeff Turnbull. I'm the Chief of Clinical Quality for Health Quality Ontario. I lead the equity part of that initiative. I'm also the Chief of Staff at the Ottawa Hospital, and I look after the inner city population. My clinical practice is the Medical Director of Inner City Health in Ottawa, so the equivalent of Philip here in Toronto. So my practice, my clinical practice, whether it's overseas or whether it's in the inner city, is dealing with the consequences of profound poverty and what that does to our health. So that's where I come from, and those are our introduced. I've already not formally introduced, but I will. Those are our presenters, and as far as I know, we don't have any conflict of interest or commercial support. This is the goals for the session, is to understand health equity and why it's a critical domain of quality, so health quality for all Ontarians, explore the impact of health inequity from a patient, provider, and policy perspective, and then identify opportunities where HQO can improve health quality in Ontario. So I was going to just begin momentarily about giving some background about why would we think that health quality, or equity, pardon me, is an important domain as it relates to all of the other domains in quality. And you saw them on that list in the presentation. That was things like timely care, patient-centered care, safety, access, or effectiveness and efficiency. But down at the bottom was equity. And so why would that be such an important domain that we're now trying to address that? So really, I think the issue is, and from a personal perspective, I was always aware of the social determinants of health through medical training. And didn't think it was all that important, frankly, until I actually started to practice and then started to work within an inner city population. And then suddenly it became so clear to me that whatever I was doing, it would never be enough unless I started to address some of those other social determinants of health. I was dealing with the downstream consequences of events that had taken place in our society many years before that needed to be managed much more effectively than is happening right now. And whereas the social determinants and social inequity is important in predicting our health, what's really become much more prominent is the fact we've recognized that social inequity is growing in Ontario. Matter of fact, it's growing in Canada at a faster rate than most developed countries, and we're winning the race to the bottom. Over the last decade, the most wealthy in our country have seen their incomes go up by 40%. Yet the most poor within our country, the lowest socioeconomic bracket, have seen their incomes their absolute wealth go down by 150%. So that gap is growing, and as that gap grows, we're going to see increasing consequences on health. And that's what we're here to try and address today. So I don't have to tell you about some of this. You all live this and experience this. What are some of the impact on health? And let me just take one parameter, and that would be in our last measuring up, the life expectancy in Ontario was 81.5 years, and we were so delighted about that. It had gone up about a half a year on average. That's great. But also in that report, we recognize that life expectancy differences between the Northern Ontario in a rural and remote setting and Southern Ontario in an urban setting, life expectancy dropped as you went north by 6 years. If you go from the richest part of Hamilton to the poorest part of Hamilton, that 15-minute drive, life expectancy is going to drop by 21 years. If you happen to live in one of Philip's shelters, the likelihood of getting to the age of 75 is only 25%. So that one parameter alone shows that there's massive health inequity as a consequence of poverty or some other factor in our society that leads us to be treated as more, or find ourselves more vulnerable as a result of that. So huge impact, and I won't go into that anymore. But if it was impact on the individuals, that would be bad, but there's also a concomitant impact on the healthcare system. The lowest 5% in terms of income in our population utilize over 50% of all healthcare resources. It's crisis-driven, it's generally ineffective, and it doesn't provide better care or better health outcomes for those populations. So we want to fix this problem because it's the right thing to do as providers and people interested in the well-being of our communities, but we have to fix it because we can't afford not to. It's just too expensive. So a greater reason why we wish to attract this, and as you can see, these individuals, generally the most vulnerable of our communities, have higher burden of disease, greater exposure, lack basic resources, and find themselves in circumstances in a complex system beyond which they can navigate. So just to tell you very briefly, and then I'll end, but to say we've been working hard on a definition for what health equity might entail. We've landed on this. We'd love to hear your comments, so feel free to provide us comments now or afterwards. Health equity is achieved when all Ontarians are able to reach their full health potential and receive high-quality care that is fair and appropriate to them and their needs, regardless of where they live or who they are. So that's where we've landed. We'd love to hear your comments. At the same time, if you think about, because people say, well, what's inequity versus inequality? Well, inequality there is when there are differences in health experience or outcomes for different populations. So I like to use the example of smoking. Smokers have a higher incidence of lung cancer. However, if you ask where is the highest incidence of lung cancer in the world, it's amongst our Inuit population in Canada. 6th most wealthy country in the world, we have the highest incidence of lung cancer in one of our populations. That is an inequity because it's a difference that's attributed to systematic differences, considered to be remedial and considered to be unfair or unequal. So that's the difference between inequity and inequality. And then, what is this? What's our scope? What can we deal with? Well, there's inequity in access. Some people just don't get access to the right care. But that has to be care that's available, accessible, and acceptable. So let me give you an example that Philip might use. We have psychiatrists. Ottawa has psychiatrists, probably the highest concentration of psychiatrists per capita in the country. Maybe we need them. Nevertheless, psychiatrists don't find their way down to caring for my population, the inner city population, where actually is the highest concentration of schizophrenia and affective disorders anywhere in the city. So we've got psychiatrists, yes, but are they available to my community? No. Are they accessible to my community? No. And is the care that they might provide perhaps to our immigrant population acceptable to many of them? No. So that's a major challenge of making services available, accessible, and acceptable to vulnerable populations. Equity and experience, we would hope that everyone would experience the need, the care that they need, the right care, right place, right time. So those are well within, I think, our domain to deal with. But health equity and outcomes, that means if you have a stroke in Philip's shelter today, as a homeless individual, or if you have a stroke and you happen to be quite wealthy, your outcome will be just the same. Does that happen, Philip? Just not on this planet. It's not ever going to happen. My folks who have a stroke are going to have terrible outcomes. Wealthy people who have a stroke are going to have good outcomes. And then the last one, the hardest one to achieve, equity in health. That means every child born today will have the same potential for health, no matter where they are, who they are, where they live. Well, we're a long way from that. So, but what is our scope? Where's our nidus of control? And I think for us, it's in the first two, access and experience, but we cannot ignore the fact that there are social determinants that are really influencing what we're doing. And then, just to say, Health Quality Ontario, just bringing that down, we provide many different aspects, advice to the system per se. We can do that by monitoring, reporting, evidence, QI initiatives, engaging our partners and our patients. So we have a certain structure that we can use to promote equitable care within this province. So our first little bit, now I'm going to introduce our presenters who are going to speak from their perspective. But I want to give you a warning. I want you to recognize that you're going to have to do some work at the end of this, because what are some of the key challenges you're facing in providing or receiving equitable care? So what's your perspective to that? And then what advice would you give us as we start to look ahead? And what would you tell us to do in promoting equity within Ontario? Primarily in health, okay? So that's the work. So I think we could turn that off now.
There's 2 empty seats. People standing at the back.
Anyway.
People standing at the back and they want to take the 2 seats.
Yeah, there's a few seats up the front if you, come on. Yeah.
No?
Unless you're, anyway, so now it's my pleasure to introduce our first panelist, and then we'll allow Madonna to present, and then I'll present Philip and Patrick. So Madonna Broderick is a mother, grandmother, community activist, star of stage and screen. Over 2 decades, Madonna battled a terrible addiction and experienced homelessness amongst many other personal challenges. In October 2000, Madonna got clean, began a new chapter in her life. After getting off the streets, she went back to school, completed a high school and college diploma, and started a career. So this is a success. This is what Philip and I deal with, and we hold out these successes on a regular daily basis, and we say, this can happen. During that time, Madonna was faced with additional challenges in her personal life. She got sick, she fell into a deep depression, lost her job. As a result of her illness, she was unable to work and is forced back into a life that is affected by poverty primarily. Unable to work and searching for purpose while trying to maintain sobriety, in 2010, Madonna was introduced to Voices from the Street, an in-depth leadership training program to enable people with lived experience of poverty, homelessness, and mental health issues to participate in policy discussions on these issues and provide public education. Since then, Madonna has had the opportunity to tell her story at hospitals, drop-in and treatment centers, and medical schools with the goal of improving services to the homeless and other marginalized or vulnerable populations. So I can't tell you just how courageous it actually is to sit and come before such an audience like that. So I'd really like to thank Madonna for coming and sharing her experience.
Thank you. I don't have much of a memory, so. My name is Madonna, and I would like to thank Health Equity of Ontario for inviting me here today. I'm 59 years old. I live alone, and I have multiple health issues, including diabetes, fibromyalgia, arthritis, COPD, high blood pressure, and high cholesterol. That's just to name a few. I lived on the streets for over 2 decades, 23 years actually, and slept on a park bench. I'm a survivor of all kinds of abuse. I'm an addict and will be clean 15 years October 29th this year. Thank you. I'm a graduate of Working for Change Voices, and I tell my story often. I've been asked why I tell the shameful, gruesome facts of my story, and the answer is pretty simple. I have had it hard. I have had it ugly. There's no doubt about it. This is a way that I can turn all this pain and guilt and shame and horror into something useful, something that matters. Today I want to share what it feels like to live in poverty, addiction, homelessness, and describe how these conditions have affected my personal health. Perhaps my story might in some small way help for people to understand how important it is for everyone to share in equitable health care. As I mentioned earlier, I lived on the streets for over 20 years in full-blown addiction. I slept on a park bench behind a tavern. October 29th, 2000, at the age of 44, I came in from the streets. I went to a detox, went through treatment, transitional housing, and then to a clean and sober women's building where I presently live today. For the first couple of years, I concentrated on only staying clean and building up a support group for myself, which consisted of people I met at Narcotics Anonymous meetings. In the late part of my second year clean, I got sick. I was diagnosed with arthritis and had to have knee surgeries. I've had many of those over the last 15 years. I've had 2 knee replacements, kidney surgery, wrist surgery, three throat surgeries, and dental surgery. I've been admitted into the hospital for pneumonia, diabetes, and most recently septic shock. Most of the health conditions that I live with now probably could have been diagnosed or treated long ago, but all of my health issues were dealt with only after I got clean. I didn't address my health issues when I was living on the streets, and for me, the reasons why I didn't address my health were simple. 1, I didn't have a health card. I don't remember what I did with it. I must have lost it on the way, and I didn't know where to go to have it replaced. Number 2, I had no way of getting a prescription filled. I had no money. I had no fixed address. 3, if I needed to rest or somewhere to take care of myself, I couldn't because I had nowhere to go. I didn't live anywhere, and many shelters and detox centers or treatment centers will not take you in if you are sick. They're not equipped or staffed, so they send you to the hospital. And number 4, I wasn't able to go to the hospital because I didn't have a health card. This was the vicious cycle I faced. I also did not want to go to the hospital anyway because I wouldn't have been able to maintain my addiction. I know now that there are resources available that could help me, but I wasn't aware of these at the time when I needed them the most. Since getting clean, I've had many visits to the emergency room, and there is a stigma that is attached to me because of being an addict. Most often, the doctors and nurses believe I am there for painkillers. They never stop to ask me about my recovery. They simply assume I am here for painkillers. The stigma still haunts me to this day, even after 15 years clean. And I identify myself to the doctors as a recovering addict, and they don't seem to hear the word recovering. I speak publicly on addictions, homelessness, health, and poverty, and yet I still cannot shake the residue and stigma of an untreated addiction. A couple of years ago, I had a 4-foot, 10-inch thick piece of roofing insulation fly off a balcony, fly down the street, hit the glass beside where I was standing, and it almost severed my arm. When I went to the emergency room, they administered morphine because I was in terrible pain. My daughter was with me, and they gave me the morphine while I was there, and when I was going home, they would not give me any painkillers because I was an addict. So my daughter advocated for me that day and assured them that she would monitor my usage of this painkiller. And so the question is, what would have happened to me that day if my daughter had not been there to advocate for me? I would have had to go home with no painkillers and suffered. And it was terrible pain. Almost 8 years ago, I was diagnosed with diabetes and was prescribed metformin. It was not explained to me about the dangers of diabetes or what I needed. I thought that the pills had me covered. My diabetes worsened, and now I need to take insulin twice a day. Fortunately, the insulin pen is covered by ODSP. However, in order to take the medication, I need to screw a little needle onto the end of the insulin pen. I do not receive coverage for these pens, and they cost $60 a box. This is not in my budget, so I'm forced to buy needle tips out of my grocery money. I was told to change the needle with every injection, but because of my finances, I use the same needle until the insulin in the pen is empty, and that's usually about 10 injections. In addition to being diabetic, I am lactose intolerant and supposed to follow a gluten-free diet. I receive about $84 a month for groceries, and this is just not enough money to buy those foods. I had a stroke a few years ago and lost the vision in my right eye. I am registered with CNIB and do get free glasses and visits to the eye doctor. However, I do not receive coverage for the test to ensure that my left eye is not at risk, and there's a 30% chance it could happen to my left eye. I am told to get this test every year, and the costs for these are way out of my budget. My fear is that because I am under the poverty line and not entitled to access the utmost best health care, I will go blind. When I came in off the street, I went back to school. I got my diploma, and I had a great job, but lost it because I was sick. This put me under the poverty line. It is not a choice for me to be on ODSP. It was my diagnosis that put me there, and I struggle every day with fear and anxiety that I will not be able to take care of my health because I live under poverty and cannot afford to purchase what I need to maintain my health. Just the other day, I received a new diagnosis, which I will keep private. I was prescribed medication so that my condition would not get worse. The medication is $250 a month, way out of my budget. So I have no choice but to watch this condition worsen. It somehow does not seem or feel fair to me that I am unable to utilize a fair healthcare system. One that is available to us all is frightening and sometimes almost paralyzing. I cry myself to sleep sometimes with fear of not being able to take care of myself and the fear of watching my body deteriorate. It is my hope that through this work that we do, and to all of you listening out there, that we can bring about change and work towards a system that truly provides excellent care for all. Thank you.
We're going to open this up for questions after we go through each one of the speakers, if we could. So I'll now turn to Philip Berger. Philip is the Medical Director of Intercity Health Program at St. Michael's Hospital and former Chief of the Department of Family and Community Medicine from 1997 to 2013. Associate Professor in the Department of Family and Community Medicine at the University of Toronto. He has helped to establish human rights-related health organizations arising from his work with torture victims, people with HIV, and refugees, and has been involved in campaigns to fight poverty and on behalf of poverty and on behalf of addicts. He is the co-founder of Canadian Doctors for Refugee Care, a national organization of doctors who since 2012 has been fighting federal government cuts to refugee health care. Philip?
Well, good morning, and thank you to the organizers of Health Quality Transformation for inviting me here. The panelists have been asked a number of questions by the conference organizers, and one is, what is the impact of health inequity from a provider perspective? You know, one of the privileges of being a doctor is the opportunity for intimate glimpses into patients' lives, no matter that person's station in life. And very quickly, physicians are provided near unconditional access to the most private details of the lives of their patients. So it is really through the eyes of these patients that I've observed the impact of health inequity on promoting illness and impeding recovery. Imagine this. In 1978, I did a house call on an aging World War II veteran in a one-room flat above a store in Queen Street, just east of Broadview. He was ailing with prostate cancer, had no effective OHIP coverage, though he was entitled, and had been the recipient of a raft of threatening warning letters from a collection agency on behalf of a downtown hospital at which he was treated, but of course abandoned because of non-payment. The only food he had in this unheated, dilapidated room was cat food. He could not afford anything else. And lying on a weather-worn kitchen table were unfilled prescriptions. The veteran could not afford to fill those either. He was shy, reserved, and disengaged from his neighbors from the city, but the letters smoked him out, and he came to the South Riverdale Community Health Center, where I then worked, frightened of the severe warnings from the collection agency and seeking our assistance. We managed to call off the collection agency and secure OHIP coverage for him. Not much has changed since then, except that premiums for OHIP have long been eliminated. Food insecurity, substandard housing, no pharmacare program, deserted by a hospital, all that still goes on in Toronto, in Canada 37 years later. Just a few weeks ago, a young HIV-infected woman came to see me asking for analgesia, pain control, for a complicated dental disease requiring unaffordable to her dental care. She walked several kilometers to get to our clinic. She could not afford TTC tickets. She could not eat due to the dental pain and was losing weight. All that could be done for her was to prescribe her medication when what she needed was a cure for her dental problem and the return of the capacity to eat. What a crazy system. Medication instead of dental care, medication instead of food. So what about a universal dental program? How about an affordable public transportation system which would allow even the poorest to easily attend medical appointments? A few years ago, the teenage daughter from a refugee family headed by a single mother and receiving benefits from the Ontario Disability Support Program came to see me for help with welfare. The young woman was bright, motivated, and in high school had marks in the mid and high 90s. She actually wanted to go to medical school. She had secured a summer job, but was told that any earnings beyond $100 would be deducted from the family's ODSP check as long as she was still living at home. She was demoralized, and we could not help crack through a policy that sapped her of initiative and guaranteed a summer in downtown Toronto absent meaningful activity. She actually eventually moved out of her home, funded her university education by working evenings and weekends, but never did make it to medical school, the burden of work and study being too heavy to maintain the high grades required for entry to medical school. We all know about the social determinants of health. For this woman, it was played out for real, inflexible rules governing welfare, the absence of a universal tuition program which should guarantee for everybody the chance to acquire postgraduate education. And finally, in 2012, the federal conservative government executed a policy of severe cuts to refugee health care for refugee claimants lawfully within our borders, claimants whose refugee determination hearings had not yet taken place. The cuts also affected, and actually still do, privately sponsored refugees who do not receive medication, dental benefits, vision care, counseling services, or even prostheses for amputated limbs. These privately sponsored refugees include the Syrians, for whom the Conservative government has downloaded the health costs of faith-based and neighborhood sponsoring groups. The Conservative government has taken refugees back to pre-Medicare days when sick and dying people were left to fend for themselves. A group of physician advocates, the Canadian Doctors for Refugee Care, has documented the consequences of the cuts in the last few years. These are verified examples. A pregnant refugee woman in labor refused an epidural because the doctor was unable to confirm her type or category of health coverage. A man requiring urgent surgery for a detached retina, without which he would go blind in the affected eye, was told by the health director of Citizenship and Immigration Canada to go home, to leave our country, and that no coverage would be provided. He received a letter 10 days later offering him permanent residency status in Canada. Or a young boy being investigated for malaria whose parents received a $700 bill for an emergency department visit and never returned for follow-up appointments. If you really don't believe me, or you think I'm too censorious or cannot fathom this happening in Canada, I strongly recommend you read the July 2014 decision of Justice Anne McTavish of the Federal Court of Canada where the cuts were challenged. She found the cuts unconstitutional and, quote, a shock to the conscience of Canadians. So what does health and equity mean to me, and what would health equity look like from my perspective? Two questions posed by the panel organizers. It will come as no surprise that in my judgment, both questions can only be answered by examining the conduct of the state, by holding government, its political officials accountable for their policies. Governments make values-based decisions all the time, which affect the lives of citizens. They make those decisions whether an allocation of funds, setting of income tax levels, or implementing policies which affect our health. There is no biblical rule which says that certain social programs which we know promote good health are unaffordable. They can only be deemed to be too costly against a template of values and priorities established by the government itself. And health equity can only be achieved by that great Canadian value of fairness, of giving everyone a fair chance, of taking care of our neighbors through state-sponsored or supported actions. Some are obvious: a national pharmacare program, a publicly funded dental program, an environmentally sound public transportation system, proper healthy food for children and seniors at least. Perhaps we should talk about adequate employment rates as a priority, and failing that, then at least raise the welfare rates. What about a basic guaranteed income? That would take care of a lot of problems and can only lead to a collective improvement in health. From my perspective, health equity would mean never again, as a physician, to have to worry about the ability of the poorest of patients to secure needed prescriptions, the affordability of taking public transport to a medical appointment, the availability of a dentist, never again to be concerned with adequate food or appropriate food for my patients, and not to be worried about newcomers being able to afford an education. Health equity would also mean to me never, ever again being compelled to determine medical treatment based on country of birth or stage in a legal process, as the federal conservative government has forced doctors to do with its refugee policies. And achieving health equity in that instance means confronting governments that deliberately make people sick, like the federal conservative government has done with the most beleaguered amongst us. How can it be in Canada that we have official federal government documents, albeit taken down from their website now, which in detail outline how certain categories of bona fide refugee claimants shall receive no health coverage for heart attacks or pregnancy? None is the bone-chilling word the conservative government uses to describe coverage in these and other situations. None. How can that be in Canada? So what to do? Well, besides the usual lobbying, drafting of position papers, letters to the editors or op-eds, appearances at legislative hearings, private meetings with officials of the state, we can vote. That is the ultimate power that all citizens collectively hold, and we should vote out any government that seeks to purposely harm any person in Canada, that passes laws and policies that make people sick. Defeating any such government, in my view, is a step towards health equity. Thank you for so patiently listening to me.
Thank you. I'm not going to guess as to who you might be voting for in the next lecture or not. Anyways, we're fortunate to have Patrick Discerny here. And Patrick was appointed as an interim assistant deputy minister of strategic policy and planning division. That was effective July the 2nd, I think, of this year. Immediately prior to this appointment, Patrick worked at the Deputy Minister's Office, serving as Director of Policy and Delivery since October of 12. He played an important role in implementing the ministry's policy agenda and delivering on a number of key ministry priorities. During his time in the DMO, he served 2 ministers and provided strategic advice and support for 3 deputy ministers. Prior to joining the ministry, Patrick held a number of increasingly senior positions in the Ministry of Children and Youth Services. So Patrick, I think, is well positioned to tell us about some of the policy challenges that we face provincially, not federally, as it relates to the issues of equity in the ministry. Patrick, thank you.
Thank you, Jeff. Thank you to Health Quality Transformation for inviting me here today. Only about 3 months in on the job. I appreciate it. And thank you to my fellow panel members. Dr. Berger, it's quite useful to hear the on-the-ground reality and perspective from your view. And Madonna, sharing your personal story takes tremendous courage. And I've had the benefit prior to this job, I've had the benefit of going around and visiting some of our LHINs and meeting with some patients, some providers, and there's really no better way to understand some of the challenges, particularly around inequity, than meeting frontline service providers and meeting patients. So thank you for sharing. When I came into the job, Anne, who works in my area of the ministry, it was one of the first briefings I took because this concept of health equity was very much gaining steam within our ministry. It's something our minister frequently speaks about and is really pushing and challenging the ministry's policy development areas and operational areas to really include an equity lens in everything that we're doing, and we'll speak about that a little bit more later in the program. So the organizers asked me to speak on what health equity means to me, us, from a policy perspective, and as I think it's fair to say, an emerging concept, and we can have that debate a little bit, but it's one of the topics that means different things to different people, and as we zero in on a definition that Jeff was nice enough to share earlier, it crystallizes that. But for me and for our team, what it's the way we're looking at this is really health inequity is ensuring improving health equity, health status. An example of that would be ensuring health equity and health status for our Aboriginal partners, our First Nations. Improving equity and health outcomes, so that, as Jeff was mentioning, that if somebody in a rich area of town suffers a stroke, is that going to be a differing outcome to somebody in a more marginalized area of our population? And of course, right now, yes, it is, and it's incumbent on the ministry to sort of drive positive outcomes and great outcomes through all areas of our population. And to me, that's about understanding the differing population health needs, and population health is in addition to health equity, one of these increasingly prevalent turns of phrase or concepts that we're talking about within the ministry. And a piece of work that we're doing within the ministry right now that we're calling capacity planning. Capacity planning being one of those things that means many things to many different people. That can be actually built form, and what does our healthcare system look like 20 years in the future from a bricks and mortar perspective. We're taking it quite a bit upstream from there. What are the care pathways and models of care to ensure health equity and 15, 20 years out from now? And that's a pretty nascent state project right now, but that's what we are getting our minds around, and it's about shifting our policy development process from one of equality in greatest good for greatest number to true health equity in terms of what do varying populations and folks need from a population health perspective to ensure the best outcomes they can achieve. And segueing to something Dr. Berger touched on, improving equity and access. And I was going to speak to another example, but I think your remarks around the federal government's removal of refugee health benefits is a good one for me to segue to. At the point that the federal government made that policy decision, the Ontario government did make a conscious effort to step into that space with the Ontario Temporary Refugee Health Program in order to fill the gap left by the federal government. And I think Dr. Berger and myself are actively watching the appeal process that's going on right now through the courts. But just to get at a question of equity, something that we've noticed through the installation of that program, the stigma that exists in that population and their willingness and comfort to access healthcare services is really been driven down. We had the benefit of sharing some information with the federal government and seeing the number of refugees that have come to the country that are accessing our stopgap program, our temporary health program, versus the uptake that was previously experienced with the federal program. It's shockingly lower. So my question would be, where is this population getting their health care right now? And that's a question that we're actively seeking to answer. In terms of a policy development process, I'm sure, as everyone in this room is informed consumers of the healthcare system and watches this space actively, it's about ingraining a health equity lens in what we put forward through our public communication strategies and our policy development strategies. So I'm sure we're all familiar with Mr. Hoskins' patient-first strategy, and really what underpins the pillars of connect, inform, access, and protect is a concept of a patient's lens and ensuring equity for patients through that. And it is certainly something that is considered at every stage of our policy development, especially at the onset. Thank you.
Good. Good. Okay. Well, I'd like to, on your behalf, thank all of the panelists for their presentations. But now it's your turn. I think it's an opportunity for all of us to ask questions. And remember, we challenged you with that we wanted to hear from you, and the two thoughts were, what are some of the key challenges you're facing with providing or receiving equitable care? And how can HQO help in addressing these key challenges? So I'd like to turn that to your attention, and the mics are in the center of the room. Nashpa's been very kind. She said she'll move them around the room as you need them. So feel free to signal to her that you'd like to ask a question. And if there's, let me just, I'll begin. I've got some burning questions. It's all about me, really, frankly. So I wanted to turn to Patrick and ask him, do we, I heard we were hearing from Philip about just how important as a provider those social determinants were, and Madonna the same way. And my experience has always been that, I work within a silo of a Ministry of Health, yet the areas that I have to deal with so commonly are, I do rounds with housing people and social workers and police officers. I deal with writs and warrants and all of the like from the judicial court system. Do we have the right structure in dealing with this siloed approach and as we try and develop policy going ahead for this important initiative? I know why we've developed it up until now, but as we create policy to address this, do we have the right structures, or do we need to think of a new way of doing business?
Thanks. Thanks for letting me go first.
Yeah, I'm going to get the hard questions keep coming after this.
Good. But I assure you, it's a question that it's not the first time that I've received a question similar to that. Yeah. But I think we can look at it from two perspectives. Do we have the right legislative framework and legislative parameters in order to break down some of the silos, work horizontally, all those good things? And then do we have the right relationships and structures within government to actually facilitate that? So from a legislative perspective, I do think that we are in Ontario in good shape. I think we have 6 or 7 pieces of legislation that one could, in one way or another, point to as having equity as a principle within there. ECFA, LICIA, the HCCA, yep. Even the French Language Services Act, the Ontarians with Disabilities Act. Obviously more can be done, but I think we're starting from a pretty strong base. In terms of the structures within government and our ability to work with one another, when we talk about breaking down silos, would it be easier if we were all one ministry in one room and having a conversation? Of course. But the reality is government is not structured in that way, and it's our responsibility to work across our structures, and that's not any different than what the private sector is asked to do, and we should be held to the same standard. Increasingly, government is launching strategies around poverty reduction. There's work going on a low-income housing strategy. that is the government's intervention or way to ensure things are driven across ministries. Mental health and addictions is another good example. There's 14 ministries around the table for that conversation. We have a leadership council, and success in my mind is we know we're doing it right when, no matter if you're asking myself in health or colleagues in children's or community and social services, that the answer with respect to what our priorities are and what our actions are in our mental health and addiction strategy, the answer is the same coming from different areas of government. That's a good barometer for me. But we do have challenges in a fair question being asked in terms of what is the articulation of the government's social policy agenda across mental health, housing, poverty. That's an easier question to ask than it is to answer, but there are work going on in the various domains that I just talked about, and it's where the linkages are between these strategies, and ensuring that nothing is falling between the cracks, nothing is being unrecognized, and that's the job of the public service, and I think that we are equipped and certainly aware of the challenges, but are organizing ourselves in such a way that giving ourselves the best chance of success.
Good.
Hi there, is this on?
Nope.
Yep.
Hi, my name is Penny Sutcliffe, and I work in public health in the Sudbury region in Ontario. So thank you, first of all, kudos for the work and the focus on health equity as part of HQO's work. It's tremendous to see. I have a lot of thoughts running through my mind, but I'll just maybe share a couple of them and be really great to hear some reaction. I think that it will be important for HCO to carve out language matters, so what we mean when we say health equity. And there was a slide up there that talked about equity in health, outcomes, equity in access, et cetera. So be very, very clear about what we mean with that. And also, if we end up limiting that scope on equity of access, so that's a tendency because that's sort of the realm of influence that we think the health system has, I would, I guess, challenge us all to think about the fact that the public health arm of the health system is part of the health system and is tasked with just that, with working with many other sectors outside of the health system. We really are a bridge, social services, transportation, municipalities, and on at the local level, but also at the provincial level. So for us to think about, as Health Quality Ontario thinks about the health equity portfolio, to think about that lever, that arm that is the public health system, and what are the, how can that be leveraged, and how can we ensure that we work together so that we're not just talking about poverty and health, we are talking about equity throughout the continuum, the gradient, but we're also not talking about patients, but we're also talking about people, citizens, communities, populations, et cetera. So I think there's really a great wealth of work that has been done within the public health system, and that should be considered in terms of the scope as we look at equity overall, equity throughout the gradient, and equity of opportunity, thinking about upstream and not only equity in terms of access to health care services.
So I'm going to turn to others about how we could incorporate public health, but I must admit public health is got to be one of our greatest champions, and I'd have to also say that in other jurisdictions where I've worked, public health plays a much greater role in population health as opposed to now some of the activities that public health does in terms of immunizing. All of those things are really important, but I think the scope and opportunity for public health is much, much greater, and it has proven to be much more effective in other jurisdictions. So we have to give them the resources and support that they need to really play that role. Other comments from the panel about public health and the role? Philip or Patrick?
I mean, public health historically has been the activist branch of medicine.
Right.
It always was. Now you hardly see them anymore, to be quite frank. Very good people work there. I have a sister who's a public health physician, so I've got to be careful what I say at this panel. We'll get back to her very quickly. But I remember in the early days of the AIDS epidemic, the City of Toronto Public Health actually assigned a public health nurse to our little private medical office to do HIV/AIDS counseling and methadone counseling. That doesn't happen anymore, but it was a concrete example of an alliance or connection between frontline providers and the state's health agency, the public health department. They do very good work, hamburger poisonings and all that type of stuff, but you rarely see public health, maybe they're constrained by political consideration, but you rarely see public health officials taking political positions with the evidence that promote health equity. I'm not sure what they're afraid of. Maybe they're afraid of the city councilors, maybe they're afraid of the Minister of Health. I have no idea. But you used to see it decades ago. There's relative silence now, which is I think what you're referring to, which is too bad, because they do have the training capacity and the research expertise and analytic expertise.
I think it's very jurisdiction
Yeah.
specific.
Pardon me?
I'm just saying you need to come to Sudbury.
Yeah. Patrick, any thoughts on that one?
The only comments I would add are, I think what is sometimes referred to as a liability or a challenge in the form of public health being a municipal, provincial cost share arrangement. I look at that as a potential asset. There's levers at the municipal level. There's levers at the provincial level. I would just wonder how collectively we can do a better job of driving some integration between, small I integration between local public health units, whether they be LIN structures to really drive at some of the integrated care goals that LINs are working on. And I know to varying degrees, public health, medical officers of health are engaged with their LIN. I know your colleague Chris Mackey is quite engaged with his, but trying to drive that level of consistency across the province. I know you're quite active in Sudbury, but bringing that level up, I think, would be advantageous to everyone.
But obviously a strong partner as we go ahead.
Yeah.
And linking public health to the community health centers through the lens is an effective strategy. And maybe depoliticizing the role of the chief medical officer. Because they'll get fired if they say something.
Yeah.
Thank you. Hi, I'm Inthias Daniel. I'm with the Ontario Hospital Association, also with IHPME. One of your questions you ask is, what's your advice to HQ? One of the things I would maybe advise on is, what I've heard so far is a lot of, at the end of the day, looking at healthy communities. And if we are looking at healthy communities, we are looking at population health and maybe integration across health systems as well as other forms of government. The advice I have for you is to ensure that the health equity is front and center. Because what I've seen this morning in the presentation, looking at the dimensions of high quality care now, you have taken away population health and integration as part of the two other attributes of a high performing healthcare system. So if you should focus on the 6 attributes, which is basically IOM, the piece that's missing is population health, and the other piece that's missing is integration, not integration across health providers, but maybe across different levels of government. So my advice to you is that you should really bring this front and center, because you've lost that ability to highlight some of these things.
Really good point. That as we start to think about that, we're going to have to make sure that we fill in the population health perspective. Down that way.
Question or a comment, observation. My name's Terry McDougall, and I'm from the North Bay Nurse Practitioner Clinic. So I'm a primary healthcare nurse practitioner. I've worked in a primary healthcare organization, a large traditional type of medical practice. I've worked in community health centers, and now I'm in an MPLC. So in North Bay, we have 12,000 patients. That's, I think, the estimate without access to primary care provider. So when I worked in the primary healthcare organization, the FO, in North Bay, there was a stark difference between working in a community health center and a FO, where it was very traditional medical care, and the attitude, the value on equity, the value of social determinants of health was just not there. I think the priority was to treat illness, because lots of ill people in North Bay, and if people didn't show for their appointments, if there were barriers to them getting there on time, that addressing those barriers was not a priority. They were just let go as patients. So I think in Northern Ontario, we struggle with building in equity in our system. And because one, it's not I see it's not a huge value. Now at our NPLC it is. So it's ensuring the established practices that it becomes a priority. And I don't know how you do that, because you can't really build a bonus payment in for equity.
In fact, other jurisdictions have done that specifically and built in incentives. So if you're going to fund a family health team of some category, whatever alphabet soup you want to use for the foes, fits, fins, whatever, some of them have looked at the demographic of the population that you're serving and given a premium for lower socioeconomic status. So your funding strategy is contingent upon the population that you serve. So some jurisdictions in other parts of the world have tried to do that. I think we can look at better performance-based systems for reward that actually enhances the right type of service delivery. But I really like your comment that, I went from a traditional model to a model that was non-traditional, and the traditional way that we had been thinking about it doesn't address equity, and the new, more innovative one does. So I think that should give us some food for thought as to what's the difference between the two models and how do we find ourselves here. But let me turn to everyone. I'm going to ask Madonna a question in a minute about this.
Thank you for the question. A couple of comments I would, and I think there's a session on this afternoon that I'm hoping to get back for around how can we use transparency, or how can we use other non-monetary forms of incentives. Given the fiscal situation in the province right now, I'm not sure a new monetary incentive is the first policy or intervention that would be grabbed at. But I think there's some possibilities there. And then the ministry, we internally could be doing a better job in disseminating knowledge exchange, some tools that we do have. I'd be interested to know how many people in the room are aware of, we have a health equity impact assessment toolkit, and I tend to think it's actually better used in the sector outside of government than it is here. It's a tool that was developed internally a couple of years ago, and it is a useful thing that has been adapted by the Wellesley Institute has done some work with it, but it does help frontline service providers, in some cases primary care organizations, in driving some equity through, or equity of access at least, through their practices.
Phil?
So,
what do you think, Philip?
Well, I think with respect, if Minister Hoskins decided that they're going to pay these premiums for socioeconomic status, it could be done within a week, quite honestly. Even from the same budget that is attributed to physician payment right now. We hear stories of physicians who roster 2,000, 3,000, 4,000 in some cases, often outside of the large urban centers, of relatively healthy patients who they're guaranteed paying for them whether they see them or not, and don't take sick patients or poor patients. So there are ways of using the money in a different fashion. That's what the role of the state is. That's what the role of the minister is. And as far as physicians being engaged in health equity, there's an iconic editorial written in the Journal of American Medical Association in June 2012. It was actually a reproduction of a convocation address given to the Harvard Medical School graduating class. I don't know if you read that or not, by Donald Berwick. And it talks about the duties of doctors in particular to use their voices loudly, and that was his quote, loudly, in defense of the interests of the poorest, the most disconnected in the neighborhood. And I think that's a value that has to be penetrated far more deeply in medical school. Even who we select to get into medical school, all of the schools try to crush it out of the students pretty quickly. I don't have to tell you, but in regard to your point about not seeing, kicking out patients that don't show up for appointments, I think that's a terrible thing to do, actually. And it really depends on the values the doctors hold. And clearly, there's another editorial in JAMA by a leading Catholic bioethicist named Edmund Pellegrino, talked about this is 1987, by the way, when he spoke about the duty of doctors to treat AIDS patients. I remember the title of the editorial was "The Newest Epidemic, Patients Without Doctors," because doctors are firing AIDS patients. And we did talk about the the fact that physicians have medical expertise and knowledge imparts a moral claim on that knowledge to them by people who need their knowledge and who are sick, which is, I think, another value that has to be inculcated into graduating students.
Just can I ask Madonna's perspective on that, and then we'll get to your other question. Madonna, have you noticed in different settings, depending on the circumstances, differing levels of care throughout your life in terms of, well, if I don't show up to this clinic, they're not going to,
Yes.
I won't get another appointment ever, things like that?
Yes.
So that's not an unreasonable. And do you think there's circumstances where that care would be better versus other circumstances? And if so, what's the difference?
Well, I've had to cancel, especially specialist appointments, for legitimate reasons, for good reasons, and they wouldn't rebook me.
They wouldn't.
They wouldn't rebook me, no. And so what happens then is I got to go back to my doctor. I have to wait for another referral to another specialist that takes months and months and months, and I just get sicker.
Yeah. So along that line, I don't know what Philip would say, but none of my patients will ever get on a waiting list. We complain about the length of our waiting lists. Well, my patients will never get on a waiting list for a total knee joint replacement. Just will never happen. They will never have access to that service, ever.
No, I agree. To be fair, there are some actually humane super specialists out there. I remember I got a call once from a cardiac surgeon who specialized in valve surgery. That's all he did, from Sunnybrook. It'll be very quick. And he phoned me because he had a patient, HIV infected, on methadone, had some chronic valvular problems. He said, I can do her heart surgery. I can't take care of the rest of her problems. Can you please find someone nearby who will do it? Which is very unusual. So I wouldn't want you to walk out of the room thinking that all specialists are bad. There are some ones who have not abandoned their fidelity to the welfare of patients.
There was a question over there.
Yes. Hello. Thank you for having me. Is it on? Yeah.
Yeah.
Thank you for the panelists. Thank you for the discussion. I'm from the Champlain CCAC. I'm a clinical lead nurse, and you asked the question about what health quality transformation might be able to do, and I was inspired to speak today from a few things that were presented on the panel. And I think, and I don't know if it's the right place, but I was triggered to speak about the disappearing middle class, the top 1%, the movement that's happening politically. I'm worried about the middle class. I'm worried about public services. I'm worried about competitive bidding and privatization and the way that Canada seems to be going and the way Ontario models of services is going. I remember feeling, the speaker this morning, he spoke about how Canada was an innovator. Canada was in first place. We're not anymore. Why? Why is this happening? Who are we being influenced by in the healthcare system? Who's making decisions? So I'm wondering if health quality transformation is the place to go where we can ask those questions and have them examine what's happening in our healthcare system. Why are we going more and more like a United States model? And is really that the outcomes that we want? Let's look at our neighbors. Are they healthier or were we healthier? So those are the kind of things that triggered I don't even know if it's a question, but it would be an encouragement of everybody to protect public services, because those are the things that will protect you and me and our children, and to really have a look at the big picture, the income earners, and who's making the decisions. Thank you.
That's very passionate and very good advice. Thank you. Let's
Do we
get a
have
few
time?
more questions. I think we do have a little bit more
Oh,
time,
good.
but we're running out.
Hi, my name is Heidi Schaefer. I'm with the Association of Ontario Health Centres. So we've been working really hard for a number of years to maximize and standardize a lot of our determinants of health and community development work. One thing that's been challenging from the HQO's need to drive system change is around the quality improvement plans, where we focus so much on disease prevention, and then we don't show up because we're monitoring disease management through Health Quality Ontario. So that's been a challenge. We're very heartened to hear when the mandate letters included this notion of a culture of wellness, because really we're working on creating those caring communities where, Madonna, you would have, you know, had more safety and ability to feel connected and probably gotten clean sooner and had more support. Maybe not. But we're working on that sort of community level around, and so that idea of the index of well-being, I'd love to see health quality really looking at that, because it is some standardized kind of measurement. And we find a lot of our centers are laying off their health promoters because they can't afford it. But by maximizing their roles in interprofessional teams, we're going to save a lot of money from the doctors who shouldn't be doing a lot of this work, and other healthcare professionals. There's a huge economic argument there. So culture of wellness, where's that going? Is it going anywhere, Patrick?
How I would respond to that is that I would totally support an articulation or a measurement in this space. The cost avoidance argument is always one that is somewhat more difficult to, and this kind of links the last two comments and a little bit what Penny was touching on as well. Avoidance, wellness in general, health promotion. I think we can all agree on the opportunity to avoid downstream costs and realize some savings in other areas that could be reinvested in the healthcare system. How to measure, evaluate, and articulate what that cost avoidance is something that, as public servants, we're made to demonstrate to our financial masters and political ones as well. And that's frankly an area that's been more challenging for us to account for or articulate.
So maybe that's something Health Quality Ontario could look at. Cost savings of determinants in health practice.
I wrote down return on investment,
Well put.
making the ROI for health services delivery, and it came from your comment and the one before about, you know, where are we going, and is this really saving us money, or is it not?
There's a question in the back.
So we have two. What do you think, Nushba? Two more?
We have three simplified questions. If we can have fast questions, we can have all three.
All right. There you have. The boss has told you.
Okay, I'm Mary McNutt. I also work with Heidi at the Association of Ontario Health Centres. I have a comment and then also a question. We really, our association represents community health centres and other community governed models throughout Ontario. We're not using incentives to support health equity. We have a health equity charter which we have developed, and it's actually at our booth. I should have brought it here, but it actually commits our centers to work really hard within centers to make sure there are equitable approaches, but it also calls on our centers to advocate for healthier public policy. So you'll find our centers, you know, calling for a minimum wage, for better oral health services. So that charter is as at our booth, so you can have a look at it. I have a question for Patrick. You mentioned that the health equity impact assessment, I thought you said in passing this was better suited for use, you know, outside of government. To me, I don't understand why government, which developed this great tool, is not using it as a lens to look at some of your own healthcare policies.
I apologize if I misspoke myself. I think it's actually the uptake has been greater outside of government, but absolutely it was developed for an internal audience, and that's something that, as health equity and the reoccurrence of this topic coming up in our discussions with the minister and our deputy, it was actually probably about 2 months ago that Anne came in and told me about the toolkit and explained a little bit of what its original intent was and how it's been used and who's been adapting it and taking it beyond what we've done. So, slight distinction.
So we have one more and then one other one, and then we're done. I'm getting the 1 minute flag.
Is this on? Okay, cool. Hi, my name's Stella. I'm a peer support specialist at Ontario Shores Centre for Mental Health Sciences. My question relates to patients who have encountered the criminal justice system. Half our hospital is forensic, and a number of my patients have gone through the criminal justice system in order to receive treatment. But during their time in the penal system, they've not been on adequate medication, their physical and mental health has deteriorated, they've lost their family doctors, they've lost their jobs, and they've lost their access to adequate housing. How can we ensure that health equity actually reaches these members of the populations who've encountered the criminal justice system, especially because we're seeing an increasing trend of impoverished and mentally ill people being housed there?
Thanks for that simple question, and 30 seconds remain. So I think we'd recognize that whole criminal justice system, which we've deinstitutionalized insane asylums, and what we've now created the largest system of mental health facilities, which we call prisons now. And in that context, health outcomes are very, very challenging. And how do we integrate health across silos? Because now we're not even federal systems. If it's 2 years plus a day, that's a federal or a provincial, but you know, those are different silos, different organizations, different funding, different way of delivering services, and different standards. We've got an awful lot of work to do, so thank you for bringing that up. And frankly, my practice is basically the farm team for the criminal justice system, you know. One more. And then
So I actually have a comment more than
Oh,
a
even
question.
better.
It's
That'll
to
be
respond
short.
to your question, Jeff. So I'm Leanne Fernandez. I'm from the Mississauga Halton Lynn. We are using the Health Equity Impact Assessment tool, so you'd be happy to know. So we've actually been driving the equity agenda for the past 4 years, and I'm pleased to say we're making some progress. But to your question, Jeff, on what Health Quality Ontario can do, the struggle we have is getting the buy-in. So as much as we can, you know, those of us that recognize the need, we've talked about equity, social determinants for a long time, people still don't get it. And as much as, again, pleased to see that it's such a strong proponent of this year's conference, but really, when people think healthcare, they think about me. And you still hear about wait times. You hear you hear those people that know how to influence the system, even from a political realm. They're the ones that are the loudest, and it's people such as Madonna whose voices don't necessarily get heard. And that's really what we're trying to impact. So you play a key role at Health Quality Ontario to drive that, and that's really what we need to utilize that to then leverage this and move this agenda forward.
Great way to end the discussion, so thank you very much. I know we're done, so I'm just going to briefly thank the panelists. Patrick, I know the ministry is focused on this, and I know that it's sometimes we direct a lot of those questions to you, but thank you for bringing that perspective, and we look forward to all of the work that's going to happen. Philip, thank you for all of the service that you give to those vulnerable populations, and thank you for the perspective of advocacy. And I'm going to give the last word of the whole thing to Madonna. And so I've said to Madonna that she's to think about what one last thing she would like to impart with all of you.
I think that it's really, really important, and this is just from my experience, to just take an extra couple of minutes to find out who that patient is rather than judging them for their lifestyle.
Couldn't it be said better? A special thanks to the organizers, Bhavna, Nushba, Mary, others. I don't see right away. Corey was here a second ago.
You know, you go.
And thank you all for coming. It was really great. We look forward to your comments.